Okay, so it sounds like we now have a quorum, and so we'll go ahead and call the meeting to order. Thank you all for attending, and we appreciate your input. Just a few housekeeping rules again to remind folks, since we're conducting the meeting primarily via Zoom, that in order to communicate appropriately, we'd like to remind folks to please keep their microphone on mute unless they would like to speak. If you do have a comment, if you could please raise your hand remotely, and then we'll see that your hand is raised and recognize you, and that would be the opportunity to comment. We'll go ahead and call the meeting to order and start with some introductions. I'm John Burley. I'm the EMS Medical Director for Monterey County.
Laura Wallen with the EMS Agency.
Teresa Rios, EMS Agency.
Jeff D'Andrea, EMS Agency.
Steve Brooks, EMS Agency.
Roxanne Superfan, EMS Agency.
I'm Noah Hoffman, Medical Director of Monterey.
Scott Houchins, Lance Fire, EMS First Responders.
Will Hiller, AMR CES.
Cassie Caldera, Natividad.
Michelle Kalinsky, Chomp.
Jeff Horner, McAllister.
Cole Click, Natividad.
Okay, well, thank you all for being here, and we'll go ahead and begin the meeting. I'd like to just open the meeting with a recognition of the firefighters who were injured recently in the Dolan fire, including 3 firefighters who were hospitalized, and the loss of the Nacimiento fire station. I'd like to go ahead and open the meeting to public comment, where any member of the public may address the committee for a period not to exceed 3 minutes on any issue not in the subcommittee's agenda. Okay, hearing no specific public comment, we'll move on to approval of the past MAC meeting minutes. If you've had a chance to review the minutes, we can get a motion to approve.
I can motion to approve. It's Michelle Kalinsky.
Thank you, Dr. Kalinsky. And do we have a second?
Jeff Horner, I'll second.
Okay, thank you. All those in favor signify by saying aye.
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 Excellent. Any opposed? Okay, the motion carries for approval of the past MAC meeting minutes. We have no specific EMS recognition today except for a general recognition for the men and women who continue to serve the county in addressing the wildfires that are currently active throughout the state and the county, as well as the EMS and fire police personnel who continue to be on the front lines of the COVID pandemic, as well as the personnel from emergency departments and hospitals. There's no specific correspondence, and that brings us to old business. And we'll start with EMS agency response to COVID and fires.
Jeff D'Andrea, EMS Agency, functioning as the MOAC presently. The MOAC through the agency has in regards to COVID-19 since March has received and coordinated more than 1,000 requests for PPE from various healthcare providers in the county, long-term facilities, hospitals, outpatient clinics, numerous agencies, dental offices, all manner of facilities rely on the MOAC for PPE and access to other products, safety products, such as sanitizers, hand disinfectants, and whatnot. The MOAC has also secured more than 100,000 N95s for local agricultural workers. That's a population of essential workers that's been particularly hard hit by COVID in the months past. The MOAC also ensures adequate supply of swabs and testing materials made available by the CDPH, that these materials are in hand for the various COVID testing sites within the county. In cooperation with professionals at SVMH, we have the MOAC handles the weekly allotment of remdesivir for all hospitalized COVID-positive patients in our 4 hospitals. And we also take part throughout the region in assuring other OAs, other counties have the remdesivir they need when we have a surplus, and it goes both ways. And that's working through the regional, the disaster medical health specialists, and the CDPH. Additionally, the MOAC handles staffing requests. We've handled requests for SNFs in the area, as well as ICU RNs at SVMH. And I want to thank Rob Ferris particularly in his help with that. In addition to COVID, the MOAC's been very busy with the Carmel and River fires. And as part of a small team of county officials, the MOAC and the agency coordinated the evacuation of Rippling River, a senior residential complex in Carmel Valley. And many of these seniors had functional needs, compromises, and access needs. And in addition to that facility, much more complex, the MOAC and the same team prepared an evacuation plan for Carmel Valley Manor as the Carmel fire was creeping westward through the valley. Carmel Valley Manor is a skilled nursing facility as well as a assisted living facility with hundreds of residents in total there, some with more complex medical needs. And that was a complex operation involving numerous transportation resources and a need for various receiving facilities. And I want to especially thank John Greathouse and Ron Lee for their help with that. And we continue, the MOAC and the agency continue to provide access to PPE as needed.
Thank you, Jeff. That brings us to policy revisions and public comment response. The following policies, as you see there, were listed for release, for public comment. Policy number, pardon me? Sorry. Just like to make an opportunity for any public comment regarding Jeff's report on the COVID and fire response. Okay, thank you. Thanks, Teresa. So we'll go ahead and move on then to the policy revisions, public comment response. Policy number 2000, scope of practice, ALS.
If it pleases the chair, I'd like to just address most all of these at a single time. As you can see in the staff report, we've released a variety of policies. We talked about these at the last MAC meeting. We received MAC endorsement to move forward with them. However, because of the changes, we did need to bring them forward for public comment. Most of them had received no public comment. We did receive public comment on the protocol T6 hemorrhage control, and the comments were related to the use of blood pressure as a indicator for the use of TXA, and also to better delineate that TXA should only be used on patients who have a pulse, and we assume that means actually alive. Dr. Ray, would you like to address the response, or I can continue?
Sure, thanks, Steve. So the first public comment, as Steve alluded to, was the incorporation of a blood pressure parameter as an indication for the use of TXA. The way the policy is currently written, we decided not to include a blood pressure parameter, specifically for the reason that we didn't want to exclude patients who were in early classes of hemorrhagic shock. That, as you're aware, hypotension is often a late finding in hemorrhagic shock, and the opportunity to administer TXA may be appropriate for patients who are not yet exhibiting hypotension, which is why we did not include a specific blood pressure parameter. The other point to consider is simply that many individuals, depending on body habitus, age, gender, and so forth, may sort of exist at a blood pressure that might be considered hypotensive at baseline. And so I'd like to open the floor for any additional public comment regarding the use of blood pressure as a parameter for TXA administration. Okay, hearing no further public comment regarding that, we'll move on to the second concern that was raised, which was to include the idea that patients with a pulse would be receiving the medication. In other words, we're assuming that the comment was geared toward not administering the medication to patients in cardiac arrest. Again, use of a pulse as a criteria for administration, you may run into a situation in a patient in class 4 hemorrhagic shock in which it's difficult to palpate good peripheral pulses. The patient's awake, they're mentating, they're breathing, they're showing other signs of life. We didn't want to use absence of a pulse as an exclusion criteria for TXA. I think our intention was that the medication would not be administered in cardiac arrest if that addresses the concern that was raised on public comment. Any further discussion or comments regarding that?
So if the concern was cardiac arrest, did you add an exclusion for cardiac arrest until Rouse?
Do we have an exclusion, Laura? Thanks, Dr. Kalinsky. We'll take a look at that, and if it's not on there, I don't believe it's on there, we can add an exclusion criteria for cardiac arrest. Any other comments? Okay. Steve?
All right, so to finish off this item, there will be two of these policies we'll discuss under new business, and the rest of them will be going into effect January 1. So the expectation is that all our field providers and hospitals will be ready to use these updated policies and protocols effective January 1, 2021. And the EMS agency will be distributing fairly soon the training materials, the aids to assist the people who are doing the training with developing, their own programs to push the information out to their folks.
Okay. Thank you, Steve. So that brings us, can we move down some on the agenda?
Yes, we're down to new business.
Okay, keep scrolling. Perfect. So that brings us to new business and policy 2351, specimen collection, COVID nasal swab staff report.
Yes, Steve Brooks, EMS agency again. So based on requests from a couple of our fire agencies to have their personnel perform nasal swab testing for COVID-19, we took a template application, made it specific to Monterey County, developed a policy to allow for the use of this optional scope skill for both paramedics and EMTs, submitted it to the state. We received approval from the state to do this. We, because of the urgent nature, we have launched this policy. It is currently in effect. We've gone through public comment along with all the other policies that we just looked at, and there were no public comments received. So at this point, the specimen collection COVID nasal swab policy is in effect as written. However, is there a discussion at this point?
Okay. Any discussion on specimen collection and COVID nasal swab policy 2351? So we'll have a motion to accept our specimen collection COVID nasal swab policy 2351.
This is Scott Houchin, motion to accept.
Thank you, Scott. Can I get a second?
This is Tina Nieto. I joined the meeting late. I'm sorry I had some Zoom problems, but I'll second it.
Thank you, Tina. And so all in favor of the motion to accept the specimen collection COVID nasal swab policy 2351?
Aye.
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 And any opposed? Okay, the motion carries. Thank you all. We'll move on to the next new business policy number 6191, data utilization and governance.
All right. Steve Brooks, EMS Agency. Again, a very simple policy to help speed along our process and to assure all of our allied agencies on what the EMS agency does and how we'll manage our data that we collect, as well as distribute and work with our other partner agencies. We've created a policy 6191, data collection and governance, to talk about how we utilize our data and how we protect it and those kind of things. So what we're looking for is ultimately a endorsement of this policy also. That's the goal today.
We're looking for an endorsement or motion to accept.
Endorsement and if there's any discussion.
Any specific discussion, questions, or comments regarding this policy?
Yeah, this is Scott Houchin. As far as access to data, is this strictly related to patient care? Are you looking at operational records? We too have some confidential records that need protecting. And I think the scope on this was pretty broad.
Hi, Scott. It's Laura Wallen with the EMS Agency. This is pertaining to
Should be green, Laura.
Sorry, it's not. Anyway, sorry, we're figuring out technical stuff here. This is applicable primarily to PHI, protected health information, so anything with patient names or any identifiers is kept on an encrypted folder, and only me, our epidemiologist, and an office assistant who does the data entry have access to that.
Laura, it's Dr. Kalinsky. So just to verify, I'm sure this has already been done, but all the administrators from the area hospitals who had been involved and concerned about the program have cleared this, correct?
It was sent out to all of them, and they've all but one hospital have agreed. No, all hospitals have agreed to submit data because of the policy.
Okay, so they reviewed and requested no changes, correct?
Correct.
Thank you.
Okay, if there are no further questions or comments, we'd like to get a motion for endorsement.
I'll motion. It's Dr. Kalinsky.
Thank you, Michelle. Can I get a second?
I'll second. This is Will Hiller from AMR.
Thank you, Will. So let's take a vote, and all those in favor of the motion for endorsement for policy 6191 signify by saying aye.
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 Any opposed? Okay, the motion carries. Thank you. The next item under new business is the January 1, 2021 policy and protocol update.
Hi, Steve Brooks, EMS agency staff again. Very much the same as what was discussed previously with when we looked at the policies. These policies are going to go in effect January 1st, 2021, and we expect that the agencies have had and are having enough time to get the necessary equipment, such as epinephrine auto-injectors for BLS providers, as well as intranasal naloxone, TXA, and be ready to deploy effective January 1, 2021.
We need a motion or anything, Steve? It's just an advisory.
It's just a staff report.
Any questions or comments regarding that? Okay. Next item under new business is 2020-2021 policy development cycle.
Steve Brooks, EMS agency staff again. And in previous MAC meetings, we were aiming to bring forward the policies and protocols that were being revised and also brought in as new policies for the policy cycle that would commence on July 1st of 2021. That was an ambitious project to move this forward a little bit so that there's more time through the process. However, due to agency staffing, a few emergencies such as fires and COVID, it became a little more than the agency could handle as, and conduct normal business. So we are going back to what has been the traditional scheduling for the policy and protocol process, and we'll be bringing the 2021 proposed policies and protocols to this body in the November meeting. And we would also, if there's any policies or protocols that you, as our constituency, our partners, find need work, and you have suggestions, please forward those to us well before the next meeting so that we can consider them for this policy development cycle.
Thank you, Steve. Any further comments on that item? Okay, very good. It brings us on to EMS System Quality Improvement Program and a staff report for CQI TAG.
It's Laura with the EMS agency. Stroke and STEMI did not meet. We haven't met the past two meetings. There just hasn't been enough content to call everybody together for a meeting. TQIC met, but going forward, STEMI, Stroke, and TQIC will be rolled into CQI TAG meeting update. So on the staff report, we had our QI plan update approved by the state. We included several metrics, and the update was shared with the EMS system in June. We discussed the membership of the committee, and just to clarify, all providers and hospitals have a seat on CQI TAG. We reviewed the purpose of CQI TAG, which is in our policy 1020 for EMS Advisory Committee, and no suggestions for changes. We settled on a number of metrics that we will be collecting going forward, and we came up with some filters for case reviews at CQI TAG. There was a discussion of APOT time, which is increasing. Census is higher in all the hospitals here, particularly lately, and all hospitals have had to implement a lot of different processes. Some have closed beds, everybody has tents set up, and you have your clean, your dirty side. We know what the reasons are for increased APOT time. We discussed setting standards for triaging patients off the gurneys to the triage area as opposed to directly into a bed if we get to that point. And some of the hospitals are at that point now. So we will be putting together a small group to discuss the standards for that. T-Quick, we did a lot of the same stuff. We clarified membership. We discussed the purpose of the group and discussion of metrics. We added a couple of additional metrics, and we are trying to focus the group more on case reviews. So we came up with 4 different types of patients and calls that will be reviewed. And then we also discussed, and some changes were made based on, the protocol T6, the one on hemorrhage control and TXA. Some of the comments were made prior to public comment and were incorporated into that policy. And as far as the TXA, that has been submitted to the state as a local optional scope of practice. The scope of practice committee is meeting on September 15th. We anticipate an approval on this.
Thank you, Laura. Are there any questions or discussion regarding these items? Okay, thank you. That moves us on to reports, and we'll start with the emergency communications drill reports and ReadyNet, MCI, and 800 megahertz drills.
Steve Brooks, EMS Agency, again, on the 800 megahertz disaster training. And as you can see, looking at the chart, that we're doing in general a very good job. We do see that SCMH has had some off and on challenges, but is able to get up towards the standard that we've set. So we believe that there's some value in this program to keep us all up, as far as our communications skills and capabilities, ready should there be a disaster where these communications are necessary.
Okay, thank you, Steve. Any specific comments or questions regarding that item? And that brings us to APOT times and a report for that.
So there is a report in the packet for APOT times. We measure these the same way the state does. There are 2 different measures. APOT 1 is the 90th percentile for the APOT time by hospital. And the first chart shows by hospital, and since January, the APOT times have increased. There was a big dip in April. The line on that chart is the aggregate volume. In July and August, Natividad and SVMH have had higher APOT times than we would have anticipated, but with COVID-19, we know all the things that hospitals have had to do, and their patients, the acuity is higher, so they're holding patients and boarding them in the ED more. A lot of this is contributing to that extended APOT time, and this tells us that the Salinas area is the most impacted. APOT 2 is a super simple chart, and what this is aggregate breakdown of wall times, and the way the state measures it is 0 to 20 minutes, 21 to 60 minutes, 61 to 120 minutes, and 121 to 180 minutes. So the blue line at the top, that is starting to come down, and the red line at the bottom is coming up. What that tells us is the number of patients being held 0 to 20 minutes is decreasing, and the number of patients being held 21 minutes to an hour is increasing. And that's what the first chart showed us as well. And again, we know the reasons for this and the challenges hospitals are facing.
Okay. Thank you, Laura. Any comments or questions regarding APOT times? Okay. That brings us on to future agenda items. Any items for future agenda for MAC? Okay, hearing none, we'll move on to announcements and items for the good of the order. Any member of the committee may make announcements or comments, and like to open the floor up to any specific items that would like to be addressed. Teresa, can we get a EMS agency update?
Thank you, Dr. Burley. Teresa Rios, EMS Agency. Attached to your agenda packet is a staff report that summarizes some of the most recent work the EMS Agency has completed. And you've heard some of those items in the report from Jeff, the MOAC, Laura with the TQIC, and Steve with the policies. I wanted to just take a moment to provide this type of report to the committee because so much of what the EMS agency does happens in the background that a lot of you don't know just how much work we do. My goal is to provide periodic reports of this type to the committee, and I must say that the summary reports that we provide do not do justice to the amount of work the staff has been doing. There are two items on the staff report that, two items that did not make the staff report that I do want to take a moment to highlight. One is related to the notification of first responders when there is a possible exposure to COVID-19 or other communicable diseases. We had a meeting with the fire chiefs, I believe was in July. They expressed a concern that they may not be notified when there is a potential exposure. There were also questions regarding who is responsible for providing that notification to the first responders. Laura Wallen researched the regs and provided clarification as to the hospital's responsibility to notify first responders. She identified gaps in the notification process. She worked with fire and law enforcement agencies, hospitals, and public health to ensure compliance with the regulations. And we are very happy to report that within 1 week of the completion of this project, Chief Blaha from Seaside emailed us to let us know that the process implemented is working. He received notification on a situation within 3 hours of this happening. So we're really glad that that worked. The other one is related to the state asking all the LEMSAs to report on all the PPE and other supplies that the state has been issuing to the LEMSAs and the LEMSAs are distributing locally. The state's goal is to reconcile what has been requested by the LEMSAs to ensure that it has been distributed to those who requested the PPE. This is not something that the state agency requested from the beginning of COVID. It is something that came to us within the last 3 weeks, Jeff? Yeah, within the last 3 weeks, they notified us that they wanted this type of report, and it is not a one-time report. This is something that we're going to be reporting on an ongoing basis for as long as we have COVID. And this is a time-consuming process. One of the things that the EMS agency did good is that we work with our county IT to develop an electronic form for the submittal of the PPE request in a database that would allow us to manage those requests. This puts us in a better position than some of the other LEMSAs. However, the way the state wants this reported and the way that we've been tracking, they're not quite the same. So we are having to put some extra work to be able to meet the state's requirements. And we have already a meeting with our county IT department so that we can make those changes to the form and in the background to the database so that it becomes a more seamless process when in the future when we're having to give this report to the state that ideally what we hope is that we'll be able to just request the report and it spits it out and not a lot of manipulation that we have to do on our side. What I want to close this item just by taking the opportunity to acknowledge the work of the EMS team. From Dr. Burley, Laura, Steve, and Jeff, they have shown true commitment and dedication for what we do. Even when Laura and Jeff were evacuated from their homes during the fires, they continue to work. I also want to thank our stakeholders for bringing their questions and their concerns to us. As I always say, with information, we can do something about things. Without it, things go unchanged. And the fact that we have been able to complete so many projects and have responded to the needs of the system, it is because of the communication that we have. So I really thank you for that. That concludes my report.
Thank you, Teresa. Any other specific comments, announcements, items for good of the order? Okay. Hearing none, that brings us to our next meeting date. We had noticed that our next scheduled meeting for MAC was coincided with Veterans Day. And so we would like to move the meeting up by 1 week to Wednesday, November 4th. Just please make a note of that on your schedules, and we look forward to everyone joining us on that day for our next MAC meeting. If there are no further comments, we'll go ahead and adjourn the meeting. Thank you all once again for being here and participating. Thank you for taking care of the residents of Monterey County and for all of your hard work and dedication to fire, EMS, and law enforcement. Okay, meeting's adjourned.